My name is Clint Bahler. I'm an associate professor of urology here at Indiana University, and I specialize in prostate cancer imaging and the surgical treatment of prostate cancer. So not all HIFU is the same, and in particular, Sonoblade HIFU enables a lot of surgeon adjustment and customization of the treatment. So one of the things that I really like doing during heat treatment, during Sonoblade HIFU, is I like to compress the prostate. That decreases the perfusion through the gland. I think it leads to less accumulation of heat in what we call the near field. So that would be the perirectal fat along the rectum. And so with compression, then we get better, cleaner delivery of heat. And I think we're seeing that on the MRI scans after HIFU. And there's publications showing that, especially for anterior lesions, if you're going to do HIFU, that doing compression as a technique, which adds minimal time to the treatment, makes the treatment more efficient and shortens the treatment times, helps give us more confidence that we're killing what we're treating. So Sonoblade, just the ability to adjust, to monitor during the treatment, is a big deal. The other thing is, during a Sonoblade treatment, I'm able to sort of sculpt the treatment using their steppers. The HIFU probe is anchored to the bed with what we call as a stepper, but it enables sub-millimeter adjustments of the treatment. So let's say on the posterior aspect of the prostate cancer, when we look at pathology, often goes right up to the capsule, may even push the capsule out, could have extraprostatic extension. And so when I treat along the posterior, depending on the risk, I want to treat right to the capsule. But if you're treating from apex to base, that's not a straight line. It's an ellipsoid shape. And so I can adjust the treatment during the HIFU treatment to follow the curve of the prostate and really feel like we're treating exactly what we want to be treating without a lot of treatment pauses or treatment replanning. You know, our treatment has changed, and a lot of it has to do with advanced technology. So you could say when Sonoblade was invented, came out clinically 20, 25 years ago for prostate cancer, it was so far ahead of its time. We didn't have MRI or PSMA PET to guide the treatments. So it was a whole gland therapy. But now, as imaging has changed, that has enabled us to do hemiablation or focal ablation. So less side effects, quicker treatment. And at the same time, as we understand the technology, there's a real benefit to the community of urologists who are doing HIFU, and our ability to share results, share technique changes, is actually very active. So it's a very, very dynamic thing. That has, so over the course of the last 10 years, my technique for treating with Sonoblade HIFU has changed and has improved for the better. And so precision is critical. And one of the things that we really like with focal ablation, with Sonoblade HIFU, is that we're able to select very small treatment regions and then add them together to create a treatment zone. So that way, instead of doing whole gland therapy, say with radiation or with robotic surgery, we can do focal ablation or partial gland therapy. It's really remarkable how unique every prostate is. And then the cancer within each prostate can be a different size or in a different region. So one of the things I like most about the Sonoblade 500 is that we can adjust that treatment as we go. So it's giving us live imaging during treatment, and then we can pause, we can adjust, we can expand or change the treatment zone or retreat the treatment zone on the spot, and really without any additional time added to the procedure, which guides us. But the Sonoblade gives the surgeon really a lot of flexibility on the treatment and on basically sculpting the treatment to follow gland shape and size as well. With Sonoblade, we can follow the curve of the gland in a sub-millimeter fashion because the probe is anchored to the bed, and we have a stepping device that enables very fine changes in the treatment. This is especially important along the rectum. So on the posterior aspect, where a lot of the prostate cancers are, near the rectum, we're able to do sub-millimeter adjustments of the treatment zone during treatment. when we receive the biopsy, the clinical data, the MRI, and potentially the PET scan, we put all these together to develop a treatment plan. And the Sonoblade software, through MIM software, enables us to do fusion treatment if we feel that that's going to be helpful. But even more, during the treatment, we're able to analyze or observe the treatment changes, because as the prostate takes in heat, it's going to potentially change in size. There's going to be some swelling or some movement of that. And so the Sonoblade device allows us to adjust the treatment on the fly. First off, the quality of life with HIFU, with Sonoblade HIFU, is incredible. So sexual function, it's pretty rare for the sexual function or erectile function to change at all with the heat treatment. So we tell guys maybe 10 to 15% of men will see a change with erections, and that's typically a minor, small change. And so that's remarkable. Urinary control, so stress urinary incontinence, is extremely rare after HIFU. So, we would say less than 3%. And so those quality of life changes are remarkable. Now, as we've grown as a field, initially it was whole gland HIFU because we didn't have MRI targeted treatment. Now we have MRI or PET targeted treatment. And so now we're even adjusting how we deliver the treatment. So now we mostly do hemiablation or focal with some treatment margin. And even more recently, we've realized, or we've adjusted to do compression on the prostate during the treatment. And so those advancements have led to remarkable treatment outcomes. One of the things that always surprises me is to see the MRI after the HIFU treatment, and we generally get an MRI and follow-up, between 6 and 12 months after the HIFU treatment. And oftentimes we'll see that the side or the area that we treated is just completely gone. So very reassuring for the treatment. Hemi as opposed to whole gland. So hemi means we're focused on one side of the prostate, so either the right side or the left side, and that really maximizes quality of life. So if we're just treating a cancer that's just on one side of the prostate, the likelihood of any quality of life decreases very low. So, the patient thinks in terms of maybe three separate aspects of that. One is their experience with the post-op recovery. And with HIFU, that's remarkably fast. So there's no incisions, there's no radiation. And so really, then there's not a lot of sensation to the prostate itself. So really it's just the post-op urinary catheter, that's the initial bother. But once that's out, it's remarkably quick recovery time. And so for the patient, that means less time off work or quicker return to their activities or to travel. But another major aspect, of course, is that they maintain their quality of life. And then finally is the cancer control, the oncologic control. And so, all three of those domains are very important for the patient experience and outcomes. Oftentimes, prostate cancer and benign prostatic hypertrophy run together. And so they can have both a prostate cancer and lower urinary tract symptoms, such as a weak stream or trouble starting stream or urinary frequency. And we know, based off of the MRIs after HIFU treatment, that HIFU effectively shrinks the zone that we treat or obliterates it. It atrophies, gets reabsorbed. And so for us, then they're just left with the contralateral or the non-treated side. And so a few years ago, for those men that had a weak stream, lower urinary tract symptoms, we started offering the cancer treatment, but at the same time, contralateral or opposite side treatment with HIFU, so they would have the best kind of long-term urinary control, urinary function. Men who have a good sexual function that they want to preserve. So men where quality of life is really important to them are the best candidates for HIFU. And And so we often target men who have intermediate risk. So the most common prostate cancer diagnosis is intermediate risk, and those are the best candidates for an ablative therapy like HIFU. Also, men who have low risk or men who are on active surveillance can also be really good candidates for HIFU because of the low side effect profile. So we know that men with, let's say, 3+3 low risk prostate cancer, if you follow them over 10 years, up to 50% will fail the active surveillance, that their cancer will progress. And so many of them are really good candidates, especially if they have an MRI lesion. So to provide active surveillance, but with HIFU, with Sonoblate treatment, thinking, and the logic is, we want to decrease the progression of that cancer to a more aggressive cancer that would require whole gland therapy. Another indication for HIFU, and one that we did a clinical trial here at IU around 20 years ago, is salvage therapy. So men who have failed radiation therapy can be great candidates for HIFU. And typically those prostates are smaller after radiation therapy. And oftentimes they're imaged with PSMA PET scans due to cancer failure. So you have great imaging, MRI, PSMA PET to help guide the treatment. And we know that redoing radiation or salvage prostatectomy comes with higher risks of incontinence and sexual function. And so HIFU, can be a great treatment option for those men. So one of the improvements was a software improvement to Sonoblate. The new software made the treatment, I think, a lot more efficient and also gave a lot more control to the surgeon. It made it easier to pause treatments, adjust the treatment zones, and it was more intuitive. The new software version was made with us as surgeons in mind, and so we were one of the sites that used one of the beta versions, and we had engineers asking, okay, where do you want this button? What do you want on the home screen? They wanted to make that it was a priority that it would be just a single screen, so we didn't have to move screens during treatment, which slows things down. And so we ended up with the software that does exactly what I want it to do, and also continues to improve and adapt as we think about the treatment. We looked at our HIFU treatment times, or the time in the operating room, and the new software alone reduced that by around 20 minutes per treatment. Of course, another factor that we think has made a big difference is the compression, HIFU with compression. And in that case, that also speeds up the treatment, and in some cases will decrease the number of treatment zones that we need to use during the treatment. And so all those together have changed my OR time so that now I can reliably have a total room time of about an hour and a half for the HIFU sonoblated treatment. And the actual on-treatment time may be 40 to 50 minutes of that hour and a half. What have I learned from performing a lot of HIFU procedures? I would say the learning curve should be fairly short with the Sonoblate HIFU device. The device follows your treatment plan. A lot of the learning had more to do with my learning curve with, say, targeted biopsies and understanding the three-dimensional shape of the prostate and how to target that. So there are some technique or device-related things that become easier, of course, as you work through the cases. The Sonoblate team can be very helpful in terms of indications, who is a good candidate, who's not a good candidate. And so some of that learning curve can be reduced by all the work that's already been done. So innovations in HIFU, the most important thing for me as a physician, it's the cancer control. I know that this patient with HIFU is going to have excellent quality of life based on our history. So the most important thing is that we maximize patient control, that we reduce treatment failures. And so one of the things I love about Sonoblate's approach is it's all focused on maximizing the heat delivery, on decreasing treatment failures. So when you think of what are new things in HIFU, and I think You could say, well, an advancement would be the console or how the heat's delivered. At the end of the day, what I care about is that we're getting the most heat into the tissue, that we have the least amount of in-field and out-of-field treatment failures. And so Sonablade HIFUs remained very committed to that. So of course, we love software updates that make the treatment more efficient, that reduce operating room time. But we've been careful, those are never at the expense of cancer control, and that we're really killing the area that we intend to be treating. Computational algorithms, or AI, which is brought to us through the field of engineering, is hugely important in HIFU. And HIFU gives us a digital interface. So, we're interacting with an ultrasound image on a digital screen. We're able, with Fusion, to overlay digital images from MRI or from PET. And so there's a huge opportunity for AI to help us with the treatment. And of course, with HIFU, prostate cancer is often a multifocal cancer, meaning it's in multiple areas, and AI can help standardize the MRI or the PET read. So I anticipate that it's going to help build a treatment plan for us. And also, Sonablade is working with engineers to develop AI so that it's actively scanning your treatment and telling you more about the treatment. So we already have a tissue change monitoring, or the TCM, to help us understand treatment. And we already have software written in that is observing the rectal wall to tell us if there's a change in that could indicate the rectum is heating up. So we already have a lot of tools, but I think it's going to get better, and AI is going to make the treatment easier for the surgeons. Sonablade was invented here. So it goes back to a chairman that we actually revere a lot. John Donahue was the chairman here in the 70s, 80s, 90s, and did a lot of pioneering work, especially in testicular cancer. But was working with engineers at Sonablade and towards the end of his career, so that I would be maybe the fourth generation who's doing Sonablade here at IU. And we see a responsibility for outcomes. So how are we helping the field to understand what outcome, that we're focused on outcomes for cancer control, quality of life, but also teaching. So the education and the training for using Sonablade. Of course, when it came out, we didn't have advanced imaging, and it was a whole gland treatment. But now things have really sped up with MRI, with PSMA PET, with hemiablation or focal ablation, such that now it's a treatment option that we feel every center is going to want to use and have access to.